We have some guests here to have really made the shift to managed care. They were sort of an early adopter of this move to Medicaid managed care, and I think have a lot of great lessons learned, and I think have proven to be very successful under this new managed care environment. Aunt Martha's Health and Wellness, as you may know, a very large FQHC here in Illinois. We have Raul Garza, the president and CEO, and Audrey Pennington, their chief operating officer, are going to come and talk about this move to value and the Medicaid managed care environment. And I should mention that Raul also is the chair of the MTAC steering committee. So Raul and Audrey were really terrific as we were putting this presentation together, helping us kind of figure out what we needed to put on the agenda, because they've been through this, they know the challenges and some of the lessons learned. So Raul and Audrey, I'm going to turn it over to you. Here, are you okay with the handheld? Yeah, we just need it for the recording, I think.
Good morning. So I want to tell you, I've had the opportunity to work with both Lindsay and Angela, probably 15 years, Lindsay, when
a long time.
You were at Presence, and then Angela when she was at Illini Care. So looks like a very dynamic presentation throughout the day. So we health center, but before we went into that work, which is just about 20 years ago, I think many of you as our partners probably remember us primarily being a child welfare and community-based services organization. And so there was experience with Medicaid back then, but then obviously that got accelerated or it intensified when we became a federally qualified health center. And if you didn't know, Lawndale Christian is also a federally qualified health center. So there's about 50 of those in Illinois. And I think my predecessor's vision into taking Aunt Martha's 20 plus years ago into healthcare as a federally qualified health center was really to get children we were serving and families we were serving either in the child welfare industry or in community-based services, so the work we do with DHS, to make sure they would have access to healthcare. I think what is true today probably was much more true 20 years ago. There was just really a lack of providers that would accept Medicaid. And I think we see that now when you talk about psychiatric care or behavioral health care and certainly oral health. So when Carrie asked me to kind of come in and spend 15 minutes in this segment, I thought about this in a way that I think Lindsay has already touched on and Angela, and that's value-based care. So she's touched a little bit on fee-for-service, and I think what remains true is that it's really hard to gauge the value of the work that we do in that kind of arrangement. Value-based care, and see if I can navigate this. So really it's a simple definition. When we think about value, it's really what are the outcomes we're achieving, and about the denominator, we're looking at really patient outcomes or evidence that the patient is getting healthier in our care, regardless of what we do. So regardless of whether you're a primary care doctor or you're a behavioral health care provider or you do substance use disorder treatment, can we demonstrate that that patient is getting healthier? And then the cost of care piece is really what does it cost to get to that outcome? So we always want to try to achieve the highest level of care we can provide for a patient with whatever it is they present with. And the cost of care, we certainly want to have that be neutral, or if we can, drive that down. Now I know that Christy Herman, who's with HFS, last week testified at the Senate hearing that when she was asked, is the shift to managed care, DCFS kids specifically, meant to save money? And she said, well, no, not exactly. If it happens, that's great, but that's not why we're transitioning to managed care. Rather, we want to improve the quality of care for kids in Medicaid who are also in DCFS. And I think what I get excited about when I think about the shift to value-based care is that it really allows for the opportunity to integrate the care in a way that does not exist right now. And so every one of us probably touches the same individual in the community in some way. We might be their primary care provider, you might be doing the behavioral health care, somebody else might be doing substance use disorder treatment. But the challenge with the current system is that we're not all talking to each other. And when we're not talking to each other, something gets lost in the translation of that care. Immediate benefit you'll start to get as we make this commitment to Medicaid, which again is a bigger part of value-based care, is that we begin to understand what our true cost of care is. And I would challenge any of us to say, we don't know what the true cost of care is. We don't. You know what you're getting paid by reimbursement, but it's a reimbursement that doesn't take into consideration your true cost of care. It's a reimbursement that's been probably antiquated, number one, and then if we've been fortunate, we may have seen increases that reflect cost of doing business, but that doesn't even take into consideration the 2 years many of us were not paid several years ago. So whatever that rate is not reflective of what your cost of care is. Things like the ability to eliminate unnecessary variations in the way you do the work, the processes that lay out the work, the ability to improve capacity with resources, and really to deliver the right process at the right time for the right reasons. And then matching clinical skills to that process, and then finally, optimizing the full cycle of care when it's truly integrated. And I would tell you that system does not exist, especially with DCFS kids. You have DCFS kids that are being seen by behavioral health care specialists or psychiatrists, and they're not talking to the primary care doctor, especially where there are comorbid conditions with that child. That results in more cost. There's no way that it just happens that the cost will be lower or the care will be better because they're not talking to each other. I think a broader theory about how to think about this first commitment into Medicaid billing as it fits into value-based care. And so this will be my last slide, and then I'll ask Audrey to come up and drill down a little bit more. But this is the next thing that's happening. And when Lindsay talks about, the trains left the station, this is an example of where that's exactly the truth. Last week, HFS announced that it's fully committed to go into integrated health homes. And so when we talk about that ecosystem, as all of us performing in a collaborative, integrated way, this is what's at the heart of it. So as we're thinking about this first investment, first commitment into managed care, Medicaid billing, is this something you want to do as an organization? Do you want to be an integrated health home? And that's a whole day presentation, but it is on the HFS website if you want to learn more about it. Maybe some of you were at one of the two town hall meetings last year. I know they'll be coming out with more education and information on the topic. But just in short, the integrated health home is care coordination for helping that patient navigate all those resources they need to respond to their social determinants, which all of you are probably touching that patient in some capacity. You want to be the integrated health home or not, but let's say you don't want to be. Most likely you'll still interface with this kind of infrastructure because it might be the integrated health home that reaches out to you for a service you're providing to that patient that's assigned to that integrated health home. Consider, again, what role will you play? Who are the partners? What do you measure? What information do you share? And then, again, how do you communicate the value of your work? Which I think is important. I mean, I think that's what we all need to do, when we talk about advocating for greater rates, I don't know how you start to do that unless you know your cost of care. And that would be a cost of care for whatever service you're providing that person, that individual, that patient in the cycle of care that you play a role in. Okay, so with that, I'll turn it over to Audrey, and then she'll just summarize. That's the way you do it.
Thank you. Good morning. Okay. Okay, so we're gonna walk through this really quickly. So this is, what do you have to first think about when you're designing your model? So first of all, you have to understand your population. Who am I serving? Where do they live? What kind of diagnosis do they have? What is their home environment? So what is the population that we're serving? And then look at your model of care. What changes do I need to make in our model of care that we're providing right now? Build partnerships. At Aunt Martha's, we're a firm believer. We want to do what we do best. And what we don't do best, we want to find a partner in the community to help us out with those services for our patients. We want to eliminate inefficiencies. Most of the cost savings is going to come from duplication of services. There is so much duplication of services, so we really want to look at eliminating the inefficiencies. And then we want to quantify your impact. How are people going to see your value if you're not able to show that to them? So that's why we want to quantify our impact. Next, so this is like key. So if anything, I really would like people to remember this, because these are the key elements that you need to think about when you think about value-based care, when you think about integrated care. And then when we talk about value too, it's value to the patient. So we have to look through the eyes of the patient. I mean, that's where the value is, right? So are we sharing care plans as providers? Just like Raul said, we're seeing the same patients. How terrible is it to them if we're saying one thing and then there's another provider down the street saying something different? We want to make sure that we're sharing our care plans and that we're giving the same message to the patients. Providers. Our providers have to buy into value. I mean, we're asking them to do things, and we have to understand, they want to understand, why do I have to ask this question, or why do I have to do this referral? It's because we want to show the patients value. We want to be able to give positive outcomes. And so the providers have to buy into the value-based model. What we did with our providers is we moved to the collaborative care model, which meant that our primary care providers do behavioral health care. So they treat our low to moderate acute behavioral health conditions at the primary care level. And what they said is like, listen, we need some more training. As a pediatrician, I do not get training on behavioral health diagnosis. So we partnered with the University of Michigan, and we've trained all of our providers in the collaborative care model. So listen to your providers. Ask them what is it that they need in order to provide value-based care. Workflows, again, looking for duplications. Post-it notes. I mean, that's a powerful tool when you actually ask your team to, okay, workflow out every single step, like every phone call, every box you have to check to see where can we create efficiencies in the workflows. We don't want people to check boxes just to be checking boxes, right? If you ask someone if they're a smoker and they say yes, what happens? Do people just go on to the next question? Do you give them health education on smoking? Do you say, do you want to quit smoking? Have you followed up with your primary care provider? Let's stop checking boxes. So look at the workflows. Partnerships, again, what is it that you do and you do best, and who in your community you want to partner with? And then technology. What tools are you using to share that information? We provide healthcare, so we have an EMR, but not all of our programs, foster care doesn't have an EMR. So some of those systems we have to build electronically through Excel, but we have to track that information. We want to make sure that when we send somebody for a referral, when we say, here's a referral to a specialist, did you go see that specialist? We don't want to just send referrals out and not make sure that follow up with the patients to make sure they actually receive that care. Next one. So this again, so you'll see this model a lot of times. They use it in IHH, they use it in coordinated care. What's the most important thing is that the patient is at the center of the care and that we're coordinating that care around them. We are doing ongoing assessments, ongoing risk stratification, and care planning. So once we do a care plan or once we do a risk stratification and we don't see improvement to that patient, then guess what? It's time to change the care plan because we want to see change and positive outcomes in patients. We want to connect people to primary care providers. So when we check a box and say, no, I haven't seen my primary care provider in 2 years, then we can say, okay, here's a list of primary care providers. And then at their next appointment, you want to make sure either you can coordinate that, make that appointment right then, or make sure that you ask the question when they come back in, did you see your primary care provider? Coordinate with any specialist, behavioral health specialist, transportation. That's a big thing. What we realized too is that if you really don't ask the question to this population, they're probably not going to tell you that they need help coming to an appointment. So let's make sure that we ask the question, do you need transportation? And that's how partnering and moving to MCOs can help because MCOs provide transportation for patients. Coordinating the EMR. So we have a web-based EMR. So a lot of our partners have access to our EMR. So even though we're the primary care provider and they're the behavioral health provider, they're able to have access into our EMR. They can see when their patient showed up for the appointment. They can see if the doctor changed the medication. They can see if they made any changes in their care plan. So that's why you want to make sure that you're sharing the care plan. And then patient ping. So this is something it's hospital notification real time. Previously, we were doing this through electronic. We were doing it 3 ways. We were doing electronic, we were doing it by phone, and we were doing it by fax. So hospitals would give us daily faxes of patients that were in the hospital. We would get phone calls sometimes if patients were in the hospital. But what Patient Ping will do is give us real-time notification if one of our patients is in the ED or admitted to inpatient. So that starts the clock to say, okay, let's put the outreach team on it to get them back into care. Let's figure out why they're there. If they got discharged, did they pick up their medication? And let's make sure you have a follow-up visit to see your primary care provider. Next. So this is just a demonstration of a particular example related to depression. So when we talk about showing your value, this is what you want to think about because you want to be able to demonstrate this to your partners. So this is an example about depression. So we manage our depression patients on a registry, which means that all of our patients in our system that have the diagnosis of depression are managed by a nurse care manager on this registry. So 10% of our patients go off the registry, which means that they've improved and they've improved on their diagnosis of depression and they're getting better. So much better that they don't even have the need to be logged onto the depression registry. 60% of our patients see improvement within 90 days, and that's because we do ongoing risk stratification. So when you have that diagnosis of depression, you're going to have a follow-up visit within 2 weeks, within 4 weeks, and we want to see improvement. If we don't see improvement, then we're changing the care plan. And that's why we're able to see improvement so quickly, because we're managing that. We want to, keep doing assessments and treatment until you get better. 77% of our patients with depression we see improvement with. And when I talked about training our providers with the University of Michigan on the collaborative care model, we've been able to have 87% of our patients with depression are managed at the primary care level. So when you talk about efficiencies, they no longer have to see a primary care provider and a behavioral health provider. They're just seeing a primary care provider, and they're getting treated for both diagnoses. When you talk about value-based care, so in the MCO world, they talk about the MLR, which is medical loss ratio, which is the total cost of care. So what is the total cost of care? Not just what Aunt Martha's is providing, it's what community-based providers are providing, it's what substance abuse providers are providing, how much is the cost to go to the hospital? And so this has been our our experience with the 3 different populations. So the first was the ACA population. So that was the population with related to the expanded Medicare. And so we've been able to have our medical loss ratio at 87%, where another FQHC that we're contracted with is showing 95%. So they, the whole ACO has been able to only see about less than 5% in savings, when we've been able to see way more in savings with our patients. And because we're eliminating duplications, we're making sure that patients are receiving care at the right place, right time. FHP, which people refer to as moms and babies, we see a 68% MLR. So that's a very low MLR when, again, that shared risk contract is experiencing 78%. And when we talk about Aunt Martha's has been in the MCO world at the beginning, so we started out with the ABDD population, which was called the age blind, deaf, and disabled population, which was one of those first introductions into managed care. And now they're called the ICP population. But because they've been in managed care with Aunt Martha's for so long, we're experiencing a 55% total cost of care, medical loss ratio with that population, where the shared risk contract is experiencing 80%. So you can tell over time, just like Angela was talking about, you can see over time how you're gonna experience that cost savings. And then lastly, again, it speaks to where we were talking about Illinois is too early to see exactly how much they're going to actually be able to save in cost savings. Because we're at FQHC, we have to report all of our information to the federal government as far as our cost of care. And so where nationally FQHCs are seeing a 20% increase in cost of care, Aunt Martha's is experiencing a 13% decrease in cost of care. Again, just because we're looking at duplication, we're making sure that when we write a referral, patients are actually going to that referral. We don't want to just check boxes. And we want to support our teams, right? We want to ask our people who are providing direct care, what is it that you need, and to make sure that we're supporting them. So that's it. Thank you.
Thanks. Thank you so much. And I think what I really loved about the presentation is that, yes, we talk about reducing the cost of care, which of course we all want to see. We want to see the cost of healthcare come down. But I think what's most important is that we also saw patient outcomes improving, right? We saw the reduction in folks experiencing depression. We saw a reduction in symptoms. We saw more primary care providers engaged in the delivery of that care, which of course creates provider satisfaction. They feel good about what they're doing. It's the perfect kind of, that's really what the purpose of managed care is to do. It's really to make sure, and I imagine that the cost of care would not have come down if you hadn't been providing the quality of care that you were. You're not going to see reduction in cost if your patients are still experiencing depression and they've get a hospitalization. It's that integration and making sure that the provider, the MCO becomes a partner with you, because the MCO, our old boss at Illini Care used to say, MCOs do certain things really well. We got a ton of data. We know the claims. We know where folks are going to get their drugs. But we're not in the community. We have a certain skill set that we do really well, but the provider community has an equally important skill set. And it's, as Angela said earlier, it's only when you bring those two together that you really see the full potential of managed care come alive. So thank you so much for that. And I know, Aunt Martha's has been on this journey a while, so, they're in a shared risk contract and they're very far down the level, but we just really wanted you to see where you can get to and what the promise of this value-based approach to caring for those we serve really pays off, not only for the provider, but most importantly for the patient and their families. So with that, thank you so much. Does anyone have any questions? We're gonna go, and I never know which way I'm supposed to do this. Yes. So you remember at the beginning, these were the questions that we wanted to make sure in this section that we kind of covered and made sure you guys felt comfortable with. why are we moving in this direction? Why are states across the country moving in this direction? Why is it so great? This whole question of moving from volume to value, not just providing services for the sake of providing service, but really providing service because we want to see improvements in care and outcomes. And then really, is it going to be better for those we serve? So just having kind of heard all this, hearing from Raul and Audrey, and any other questions you may have, how are we feeling about diving into the next section? Does anyone have questions or people need more? Oh, Jesse, I know you.
I don't want to get us off to the weeds, but I'm curious if you were able to see any of those great outcomes, and you mentioned this with transportation, but by addressing the social determinants of health. And you had housing up there as one. So I'm curious to hear a little bit about how you work with those issues, with patients that come in that are experiencing homelessness or have kind of other social determinant needs that you've identified.
I'll just say, historical level, so probably about 17 years ago, we had a desire to want to take an integrated approach to care, and what that meant was really piloting screening for depression in the primary care setting. Now, I know it's a little more in vogue now, but think about it 17 years ago. And so we certainly didn't understand how to do that. So we reached out to Columbia University out of New York, and they were seeking for partners to pilot screening for depression in the primary care setting. So we went through that experience, and we focused on children and adolescents. That gave us the opportunity to really understand how prevalent that diagnosis was with underserved communities. And then it was a year later that we expanded that to adults. And then, as you know, when you're out there diagnosing for a diagnosis and you find it, then you have to build the capacity to serve it. And then we started building the capacity to serve it with behavioral health care. And I would say a big part of it is telemedicine now for us. But 20 years or 17 years later, how does it work day to day with beyond depression or behavioral health?
Sure. So the answer is absolutely. I mean, we have a large care coordination team. We believe that the social determinants of health directly affect the primary behavioral health conditions that they have. So our care coordination team, again, when you talk about if someone checks off that they don't, have access to regular food or they're experiencing homelessness, those boxes go straight to our care coordination team. They find out where the patient is living, what are the resources in their community. They directly reach out to the patient and then start connecting them to homeless shelters, connecting them to food pantries. We absolutely believe that has to be addressed. I will tell you that so many times, again, you talk about a patient population that is still very prideful, right? You reach out and you don't get anything, and so we have a large outreach team that actually goes and finds patients in the community. And so when we're able to see their home, we ask them, to see with their eyes, what are they seeing in the home? So that we can ask those questions so that they don't have to initiate some of that, right? So we can see kids don't have coats, or we can see there isn't food in the house. And so we can ask those questions because we want to be helpful. We're not going to be able to treat your kid's asthma if mom's thinking about, what's going to happen today or what's going to happen the next day.
Anybody else?
And I would have just add that we
sorry,
have
Rob.
many memorandums of understandings with our partners. So I mean, probably 100, I'm thinking, in every community that we're in. So it's not possible for one organization to really have that kind of impact. I mean, obviously we present that as our experience, but there's a lot of providers that make up that kind of those kinds of outcomes. It's not just us; it's the 100 relationships that we have with other community providers.
Yeah.
Here, let me. Can you just summarize?
Do I need to repeat that just for because we're video recording? And you know what, I'm gonna actually just give this to you because I'm not gonna get it.
I was just speaking to the capacity of the partners that you are referring to with the MOUs and their capacity to actually provide these non-medical needs, since that's the way we're going in terms of meeting those needs. Have you ran into any problems with that being a scarcity?
Absolutely. So there's a scarce of resources of housing providers, right? There's a scarce of resources of substance abuse providers. So, yes, we definitely run into those barriers, but again, it doesn't go off the list, right? So just because I made a referral, what's important to our care coordination team is when did they get connected to care? So it never kind of drops off, right? So we want to make sure, okay, well, if you are experiencing homelessness, you're staying with your cousin now. Okay, so are you still staying with, okay, let's try to figure out, where's the next place for you to go. I will tell you too, we try to look at some of those savings that we're experiencing and what are other things that we can do. We've been looking at master lease agreements with a partner that we have so that we can temporarily house someone who keeps going into the ED because they really just go in there to go to sleep, right? Because they don't have anywhere to go. Where can we house them to get them stable enough to be, transitioned into the community, into a housing program? So we're trying to be creative also.
Do you have any financial agreements with your partners in the community?
So presently, we do not have any financial agreements. I would say that what we do is we have really strong partners, right? So we make sure that when they're connecting their patients to us, that we VIP them into our health center. We've always done that with the DCFS population. We do that with a lot of our providers who have, come up with a behavioral health diagnosis and need access to a psychiatrist. You want to talk about, scarce resources. Psychiatry is one of those things, but because we have partnerships with those agencies, we can VIP them into psychiatric services. So there isn't any financial or monetary exchange between the two partners, but we prioritize them and they prioritize us.
Okay, now I have a question. Can you talk a little bit about how the MCOs have been a partner to you, good, bad, indifferent? How has that relationship changed over time?
Right. So I would say the bad was, a lot of what people experience in the beginning, the whole eligibility. How do you get everybody to understand how you, do eligibility? How do you get people to understand pre-authorizations? How do you get people to understand consent? So that was kind of the pain, but that was, several years ago. I would say the MCOs are a great partner. When you talk about you want to know what's going on with your patients, then you should be connecting to the MCOs we talked about. They have a boatload of information, and you need that information, right? How can you connect with them if you don't have an electronic system to a hospital to say, how can I get information from you when one of my patients shows up in the hospital? Maybe it won't be real time, but maybe it could be a day or two later, but you're still able to follow up. Then you're able to see what medications were changed. So much of cost savings in the MCO world and where we're experiencing value-based will come from medication reconciliation. So that's one of the things too. And then transportation, that's been like a huge benefit for us, for our patients. Again, I think it's underutilized, but a lot of that is because we don't ask the questions. We just assume, oh, they didn't show up today. Oh, they didn't show up again. They're a big no-shower, right? Instead of really asking the question, do you need transportation? Or do you need bus fare too? Another way we can be creative, we get bus cards. So we give our
and
patients.
many of the plans do the same. But,
Yeah.
but that is an important one because I think it continues to be an underutilized resource. Mm-hmm. All the MCOs provide medical transportation to appointments, often, dropping off, pharmacy delivery, things like that.
Right.
So they really do try and support that primary care experience for the member.
I was going to say, as you go into this experience, it's really an important relationship to develop is with the MCOs. I would agree that probably 5 years ago, when there was a transition in the administration, it was horrible planning probably by the administration, not really, when the big shift of Medicaid patients went into managed care, it just wasn't really thought out well. The plan was, we saw backups in our payments, and that was because the technology wasn't laid out between the state and MCOs, but it was really people like Angela and Lindsay that really helped resolve those issues. And those MCOs are committed, and they have a great leader you'll hear from this afternoon, Sam Olsfry, who oversees the Association for Medicaid Health Plans. And so she'll be able to give you a lot of great insight on that. But I think it's important for all of us to really develop those relationships because they do want to do the right things, and I think they work hard to try to resolve any issues.
Anybody else? And that's perfect, because that's a great
Perfect
segue to
segue.
Angela. Couldn't be better.
Thank you.
Thank you so much, Raul and
Thank
Audrey.
you so much.